Before you insert the otoscope, inspect the pinna and post-auricular skin. Gently palpate the pinna to find out if any tenderness exists. Now, inspect the entrance to the ear canal for any debris or pus which might interfere with the exam. To make insertion of the speculum easier, you'll need to straighten the outer ear canal. For adults, retract the pinna upwards and backwards. For children, retract the pinna horizontally backwards. Hold the otoscope like a pencil between your thumb and forefinger, with the ulnar aspect of your hand resting firmly but gently against your patient's cheek. This way the otoscope will move in unison with your patient's head if he or she turns or moves, avoiding possible injury to the ear canal. As you conduct the examination, it's normal to adjust the line of sight and the position of the speculum to completely view the entire ear canal in all areas of the tympanic membrane. To help you determine tympanic membrane mobility and recognize many middle ear disorders, sometimes you'll want to use a pneumatic attachment. When you do, make sure you choose a soft spec speculum large enough to fit snugly into the ear canal to establish an airtight seal. Use the same hand position with the bulb of the pneumatic attachment in your palm. By gently squeezing the bulb and observing the relative movements of the tympanic membrane in response, you can obtain vital diagnostic information.
So James, I'll have you tilt your head just slightly away from me. That's perfect. Okay. And the other side. And just tilt your head slightly away. Perfect. Okay.
Let me know if anything bothers you.
Okay.
Okay, now I'm going to check your other ear.
Okay.
Let me know if anything bothers you or if it's painful.
Okay, it doesn't hurt. Okay, looks good.
We'll now talk about the examination of the external auditory canal, the tympanic membrane, and the middle ear space. When we're examining these structures, we use an instrument called an otoscope. An otoscope also has an attachment on the side of it here to which a bulb can be attached. With this bulb, I can pump pressure through the otoscope and actually see the tympanic membrane moving. If the middle ear space contained fluid, the tympanic membrane would not move. So it is a very good diagnostic tool for diagnosing things such as an otitis media with an effusion or an acute otitis media with pus behind the eardrum. Before I insert the otoscope, I need to use my ensure that I do not cross my hands. So I use one hand to grab the pinna of the ear and pull it up and outwards in order to straighten the external auditory canal. The next thing I do is I take my otoscope and I rest my hand on Brittany's cheek here and insert the otoscope into her ear, taking care not to go too deeply, as this will cause her pain if the otoscope actually contacts her bony external auditory canal. Then I can look through the otoscope and examine the necessary structures of her ear. So I've now moved to Brittany's contralateral right ear and I'm going to examine it. As you will see that I need to switch the scope from this hand, my left hand, to my right hand now in order that I don't cross hands. I now use my left hand to pull on Brittany's pinna to straighten the external auditory canal out. This is also an important clinical finding in otitis externa. If Brittany had inflammation of her external auditory canal, this would cause her significant pain. Again, I rest my little finger on Brittany's cheek here and then insert the otoscope. The importance of this type of physical examination or formation of my hands is that if Brittany were a small child and if she moved her head, my otoscope would move with her. If I was not resting my hand on Brittany's cheek and she was a little child, she would move her here and the otoscope would injure her external auditory canal. This is why it's important to rest your hand that's holding the otoscope on your patient's cheek and then insert the otoscope. We're going to use a rigid telescope or endoscope here and insert it into Brittany's ear to highlight the important structures that you should be seeing when you look with an otoscope. So I'm going to pinch, again, grab Brittany's pinna here with my thumb and my index finger and pull and straighten out that external auditory canal. And the part that I'm straightening out here is the membranous or the cartilaginous portion. As I insert it and move past the hairs of Brittany's ear, we can see the bony external auditory canal and a beautiful view of her tympanic membrane. We can see, I'm just trying not to hurt Brittany here. We can see here the annulus of the eardrum, the malleus, the incus, the stapes, and the chordae tympani nerve running across the eardrum. The eardrum is in normal position, it has no perforations, and the middle ear space appears relatively clear. And here is the round window of the middle ear as well. Okay?
Let's take a look inside. So, I'm actually just going to inspect the outside first. So, just looking for any signs of infection or any clogged pores or anything like that. I don't see anything of concern. Then I'm just going to go inside. Just pulling the top of your ear. Just let me know if you feel any discomfort, okay? Okay. I'm going to go a little bit deeper. So far the canal looks really good. There's a bit of cerumen, but it's quite healthy yellow color. And I'm just going to visualize the tympanic membrane. It does look a little bit white, so slightly opaque, but I'm still able to very clearly see the cone of light and the bony landmarks. There's a little bit of vascularity, which I think is normal. Is that uncomfortable at all? Is that okay?
No, feels fine.
Okay, I'm just going to go in one more time. I don't see any signs of infection. And the ear canal looks a nice flesh color. Yeah, so no contraindications on this side for the ear candling, so that's good. Great. Let's take a look on the other side. Again, we're going to start with inspecting the external ear. The skin looks very healthy. Great. Clean. We'll do a little bit of cleaning before the ear candling. So I'm just going to pull the pin out of your ear and work my way in a little bit. And just a little bit of cerumen. It's a nice yellow color. And then the ear canal is also not red. That's good. Okay, I can see the cone of light. There's no signs of bulging of the tympanic membrane, no perforations, bony landmarks are present. It's a nice translucent membrane, so that's good. This ear looks very healthy, and again, no contraindications for the ear candling procedure.
So I'm just going to go ahead and look in your ear. I'm going to look at the canal. Okay. And I'm assessing the ear to look at the inner structures, the tympanic membrane. Look, make sure there's no bulging. Note the color. And I don't see any scarring. Wonderful. We'll do the same for the other ear here. No pain. Nope. Okay. And I don't know any abnormalities or lesions on the ear. I'm assessing for the same things in this ear. I don't see any scarring, redness, no inflammation, no drainage. And that looks really good.
Extend your little finger and use this to rest against the patient's face. This means that if the patient moves his head, your hand and the otoscope will move with it, and the otoscope will not stab into the ear canal and cause pain. This is of particular importance when examining children. With your free left hand, pull the pinner gently upwards, outwards and backwards to straighten the external ear canal to allow a better view of the tympanic membrane. In children, pull the pinner down and back instead. Insert the otoscope into the external auditory meatus and inspect the canal for wax, discharge, inflammation and other abnormalities. Gently proceed down the canal until the tympanic membrane is seen. Move the speculum around to examine the whole of the tympanic membrane and identify the normal landmarks. This is a normal right tympanic membrane. On a normal tympanic membrane, you should be able to see the handle of the malleus, the light reflex in the anterior-inferior quadrant, and the pars tensor. You should look superiorly to see the pars flaccida also. Gently remove the otoscope, continuing to observe the ear canal for any pathology that may have been missed on the way in. Repeat the examination on the other ear. When examining the left ear, hold the otoscope in your left hand, again holding it like a pen between your thumb and index finger, and using your little finger to rest against the patient's cheek.
Go ahead and look inside your ear. So your ear canal is clear, no impaction, erythema. Your tympanic membrane is pearly gray, which is normal. All landmarks visualized. I'm going to check the other side. Any pain or tenderness? Mm-mm. Excellent. All right, tympanic membrane is pearly gray on this side as well. All landmarks visualized. A small amount of brown cerumen in your ear canal, so you just got a bit of earwax.
Okay, in your ear canal, there's no redness, discharge, swelling, or lesions. Your tympanic membrane is gray, shiny, it's pearly gray, shiny, and translucent. Your umbum and manubrium and short process are all visible, and your cone of light is present in your left ear at 7 o'clock. And I would do the same assessment in your right ear, and everything would be the same, but only your cone of light would be visible at the 5 o'clock position, not the 7 o'clock.
Do the endoscopy exam now. I'm examining the external auditory canal, the tympanic membrane, the malleus, umbo, and cone of light. You're going to feel a small burst of air as it touches the tympanic membrane mobility with infiltration. Now I'm going to look in this ear, examining the external auditory canal. the tympanic membrane, the umbo, malleus, and cone of light, and you're going to feel a small burst of air as I test the tympanic membrane mobility with insufflation.
When I look inside the ear, I'm going to use the biggest speculum that fits. I'm going to pull up and back for an adult, and I would pull down for a child. I'm going to pull up like this and look inside. And I'm looking for the tympanic membrane. And there's no evidence of any cerumen or foreign body, and I see the tympanic membrane in there. It is pearly gray, no evidence of any distension or anything, no scar tissue, and the light reflex is about 5 o'clock, so that's good.
Just continue looking straight ahead.
And then I'm going to check tympanic membrane motility by insufflating. Okay.
Okay. Okay, your ear canal has no obvious lesions, bleeding, discharge, or redness. Your tympanic membrane is pearly gray, shiny, and translucent. Your umbum manubrium and short process are visible, and your cone of light in your left ear is present at 7 o'clock. And then I would do the same thing on the other ear, but the only difference would be that the cone of light would be at the 5 o'clock position instead of 7 o'clock, okay?
Next, examine the ear canal and eardrum using an otoscope. To do this, select the largest speculum the patient's ear canal will accommodate. Position the patient's head so that you can see through the otoscope comfortably. To straighten the ear canal, grasp the auricle firmly but gently, and in an adult, pull it upward, back, and slightly away from the head. Insert the speculum gently into the ear canal, directing it somewhat downward and forward, bracing your hand against the patient's face. Note any cerumen or earwax that may impair your view. Also, observe for any discharge, foreign bodies, redness of the skin, or swelling. Maneuver the speculum until you can see as much of the eardrum as possible, including the pars flaccida, if possible, and the margins of the pars tensa. Note the color and contour of the eardrum with its distinct cone of light. Normally, the drum is pearly gray. Also, note the position of the handle of the malleus and inspect the short process of the malleus. The handle of the malleus, with the umbo at its tip, crosses the eardrum obliquely from the cone of light upward toward the short process. Be sure to examine the other ear in the same manner.
Attach a new disposable ear tip or speculum. It's best practice to examine the healthy ear first. This allows you to see the patient's normal ear anatomy and compare to the other ear while helping to prevent the spread of infection. Straighten the outer ear canal to make insertion of the speculum easier. Guide the otoscope into the patient's ear to view the canal and tympanic membrane. Adjust the focus wheel during the examination if necessary. With a basic otoscope, you may need to pan around more to get a complete view. After the examination, the used disposable speculum should be removed and discarded. Twist the speculum off by hand or rotate the MacroView tip grip to eject the speculum. The insufflator bulb can be used to help determine if there is fluid behind the eardrum, which can be a sign of infection. Using Welch-Allen soft seal tips can help provide a better seal against the ear canal wall, making it easier to see movement of the tympanic membrane.
I'm going to pull the pinna up and back before I insert this into the ear canal. So when I'm inserting this in the ear canal,
I'm looking for what's called the tympanic membrane, or the eardrum. And the reflection of the light from the otoscope will make what's called a cone of light on the tympanic membrane.
To examine the patient's ear, hold the otoscope in your dominant hand. Between your thumb and fingers, pull the pinna of the ear up and back to straighten the ear canal. Remember, you'll need to look in all directions to view the entire tympanic membrane or eardrum. Now inspect the external ear canal. You should not see redness, lesions, swelling, or exudate. Now examine the tympanic membrane or eardrum. It should reflect the otoscope's light and should appear shiny and gray with a white periphery. Its center should be concave with no perforations. Note the malleus and the light reflex. Occasionally, you may see the incus. Finally, withdraw the speculum. If you see exudate on it, change the tip to prevent cross-contamination.
Alright, you have minimal cerumen, which is good. I do see some like flakes, but that's fine. Alright. Any tenderness there? Mm-mm. Okay, good. I also don't see any redness or bleeding or foreign bodies, which is great. Right now I'm looking at your tympanic membrane. It looks nice and healthy. It's a good pale color. I don't see any edema or perforations. I also see the umbo, which is at a good angle, and it also does not have any like redness or swelling on it. I don't see any scar tissue, which is great. Alright, I am unable to see the cone of light, but if I could, it would be towards the bottom of my visual view here. Alright, looks really good. And then normally I would look into your other ear as well.
The otoscope exam allows for examination of the external canal and middle ear. With a disposable specula on the end of the otoscope, hold it like a pencil. Use your little finger side of your hand to stabilize the otoscope from going deeply into the patient's ear. With your hand, gently pull up and back the ear. Work gently and quickly to observe the colors of the tympanic membrane in the canal. Look for the cone of light reflex on a pearly gray tympanic membrane.
Okay, noting that the canals are patent, the team has visualized it's pearly gray and translucent. Landmarks are also visualized. We'll do the same thing on the other side. Tender there?
Yeah.
Here? Nope. Okay, take a look in the ear. Okay. And again, the landmarks are visualized with the cone of light, the umbo, and the malleus.
Looking in for any discharge or swelling. Also, I'm going to be looking for the tympanic membrane inside and also the cone of light.
The instrument may either be held this way to enter the canal or this way. Either way is acceptable. The most important part, though, is pulling up, out, and back to straighten the canal. In doing such, you will straighten the canal, place the speculum into the external auditory canal, and visualize the external canal and the tympanic membrane. You'll notice the malleus, the umbo, the light reflex pointing anteriorly, and perhaps other ossicles in the middle ear. To examine the left ear, the examiner uses his or her right hand to pull on the tragus and earlobe up, out, and back, and the otoscope can be entered into the external canal either as was demonstrated on the other ear or held in this manner, and the speculum is inserted as I'm demonstrating now.
Next, I'm going to take a look in your ears. I notice that the canals are smooth and pink and free of swelling, discharge, lesions. And I can visualize the tympanic membrane and all of the ossicles there, as well as the cone of light. So we'll take a look at this side. And again, the canals are smooth pink without debris, discharge, swelling, or lesions, and both tympanic membranes are gray with clear landmarks and a cone of light present.
So I'm going to have the patient tilt her head. You're going to hold the otoscope like a pencil, placing your fingers against the patient's face in case they move, and then gently insert the otoscope. And while inside, I can see that she has minimal wax. I see the cone of light and the malleus. Okay. Now I'm going to do the same thing on the other side. You're going to hold it in your left hand like a pencil. Same way. Do a visual check first. Pull up the pinna to make sure the ear canal is not collapsible. Tilt your head. Again, place your fingers against the patient's face and insert the otoscope. Okay, and the same thing in here. I can see there's also minimal wax on this side, the cone of light, and the malleus. Okay. So there's no need to refer her, but in the event that you do need to refer, if there would be blood in the ear canal, a foreign object, or if you can smell the odor of an infection, and then they would be referred to a doctor.
Hello, my name's Misha. I'd like to examine your ear today. Is that all right?
Yes, that's fine.
Great. Thank you. I'm going to examine the other side now.
That's fine.
And you place it in, and what happens is now I got a good seal, and the patient will tell you it doesn't hurt. You can actually press kind of firmly. Then you hold this in this hand, and what you're going to do is, when you're visualizing, you're just going to kind of go like this. That's all you need to do. If you have a good seal and you do this, you will hurt the patient, and maybe, I've never blown an eardrum, but I guess you theoretically could damage the eardrum if you do this kind of action. So I've seen people do this kind of action, but without a good seal, it won't damage it, but it's not very effective. So when you do this, you tug, and then you just show the bulb here. You just do this kind of action, okay? Your instrument, pull back, and then start, once you visualize the eardrums, yeah, hers goes in and out very easily and it doesn't hurt, okay?
Always steady the hand that holds the instrument on patient cheek and examine the entire tympanic membrane. Here, he has an intact tympanic membrane, pale gray, glistening, of semi-transparent quality. Long process of incas is appreciated, and cone of light is preserved. While in left side, he has ear discharge, which is yellowish, offensive, with central perforation.
If I place the speculum here, just gently on Satisha's tragus, see how I'm just placing it just inside the ear canal at the tragus. Why am I putting it there? Because that gives me a place to rest it so that I know where I am before I start looking through the lens. What you want to do is have your speculum stay in one place, not go any deeper than this while you're looking through the lens.
So I've got the speculum held at the tragus, and notice also that I have my hand against his cheek. So I'm bracing my hand against his cheek, and if Satish moves his head, move your head a little bit, Satish. If he moves his head, I'm not going to be pushing the speculum into his canal because I'm bracing against his cheek. So that's critical. I'm braced against his cheek, and my speculum is just resting against the tragus of his ear. That's when I look in through the lens. And already, with the speculum going in no further than it is now, I can see what I want to see. Just by moving my head here and changing the angle of my vision, I can now see the short process of the malleus. I can see the malleus itself, and now the umbo and the light reflex. Notice I'm the one who's doing the moving, not Satish. And I'm the one who, by orienting, not moving the speculum in any further into the canal, but just by orienting it differently, I can see what I need to see on the tympanic membrane. So moving over to the other side, here I am with my otoscope again, but now I'm going to change hands. Now I'm holding the otoscope like a pen in my right hand, and that frees my left hand to pull the ear up and out like I was before. The short process, the malleus, the umbo, the light reflex, all visible from this distance. If I want to get a closer look, I can move in. But really, everything is visible from back here with the speculum barely in the ear canal. Now, of course, it's easier because Satish doesn't have a whole lot of wax in the way, and smaller children will have smaller canals, and they may have an accumulation of wax. But in my experience, by pulling on the auricle and moving it around, you can straighten out the canal a whole lot and really make your life a lot easier in visualizing the tympanic membrane. Better that than trying to shove this long speculum into the ear canal and risking damaging skin or hurting the patient and making them fear doctors for life.
Take her ear like so and pull directly back. My hand will go on the side of her face for an anchor, and I'll use the tip to simply slip the tip into her ear, and so that it's good in the center. Then I will visualize. I can see the gray shiny of her tympanus, and no evidence of inflammation or anything else. You have the cleanest ears I've ever seen. Okay? Very good. All right. Now, if there was an inflammation, it would be easy to see because it would look like a sunset. Okay? You also have to watch out for blockages, growth, and things that may go bump in the night. Okay? Again, nice, clear tympanus, no signs of inflammation, no wax, nada. Okay? Very nice. My ear should look so good.
I'm going to pull up and back on your ear, and if I cause you any discomfort, just let me know, okay? Pencil. Rest it on your ear. Ease into. See a light reflex. Very little wax. Malleus. No drainage. Pearly gray. Very good. You see it? I'm going to pull up and back on this one. Into. Light reflex. No wax. Pearly gray. The handle of the mallet. And no odor. Very good.
In using the otoscope to examine the ear, pull gently posteriorly on the helix, a maneuver that straightens the normally S-shaped canal and allows for better visibility. One should use the largest speculum that the ear canal can accept, as this increases visibility.
Another way to hold the otoscope, which is especially helpful in children, is in a rather upside down position. which gives added stability.
It is important to remember that when inserting the speculum to stay on the cartilaginous canal. As already mentioned, the bony canal is quite sensitive. You need to remove any wax out of the way to better visualize the tympanic membrane. The tympanic membrane may be silver or gray in color and translucent or opaque. The most prominent anatomic feature of the tympanic membrane is the handle of the malleus, which sits in the tympanic membrane and is somewhat anterior in position at its distal end. Extending from the distal end of the malleus, also known as the umbo, is the light reflex. This will help orient you towards the anterior-inferior aspect of the tympanic membrane. It is important to remember that the presence of a light reflex doesn't necessarily mean that there is a normal middle ear. The light reflex is important in evaluating pneumatic otoscopy for the mobility of the tympanic membrane.
Now I'm going to assess the tympanic membrane mobility by puffing some air into your ear canal and checking the movement of the tympanic membrane as I do that.
This needs to be done and documented on every pediatric patient and be accomplished on every adult whenever possible. In the pediatric patient, the tympanic membrane may appear to be normal but have no mobility, suggesting the presence of an effusion in the middle ear.